Hi, everyone. Thanks so much for joining us today. We'll get started here in a minute or so. Hi, everyone. Thanks so much for joining us. We'll get started here in a minute or so. Okay, let's go ahead and get started. So thank you for joining us today. I'm Jenny Schitter. I'm the Director of Public Health Data at Big Cities Health Coalition. BCHC is a forum for the leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of more than 61 million people they serve. Together, these public health departments directly affect the health and well-being of about 1 in 5 Americans. So here you can see the full list of our 35 member jurisdictions. BCHC focuses advocacy on several core issues, and one is the need to prioritize public health data modernization. We need more local data, not just at the county level, but at the city level as well. Tracking trends at the local level helps inform policy decisions and can identify those that are working or those that may not be. CDC has expanded its investment in data modernization at the local level, and we urge this commitment to continue through dedicated congressional funding and CDC engagement. We've been doing our part to improve the access to local health data by creating the platform you will tour today. 3 decades ago, a group of big city health epidemiologists created the Big Cities Health Inventory, or BCHI. They published chart books on a semi-regular basis to share information with peers in other jurisdictions so they could benchmark health indicators. In 2015, BCHC relaunched the project as an online platform with funding through CDC. And finally, in 2019, we partnered with the Urban Health Collaborative at Drexel University's Dornsife School of Public Health. The Urban Health Collaborative was created to leverage the power of data, research, education, and partnerships in order to make cities healthier, more equitable, and environmentally sustainable. The team at Drexel that you'll hear from today has managed that day-to-day work and upkeep on the platform over the last several years. So shortly, we'll discuss the new features of BCHI, which you can find at bigcitieshealthdata.org, and we'll drop that link in the chat, so feel free to open it up and follow along. But before we dive in, I do want to share that the platform is primarily supported by CDC. And our BCHC staff time is supported by a number of health philanthropies from whom we have ongoing grants. So the views expressed here do not necessarily reflect the views of CDC or BCHC's foundation funders. So with that, let's jump right in. If questions arise during our conversation, please feel free to put them in the Q&A box and we'll answer them later in the webinar. But now I'd like to introduce Dr. Amy Auchincloss from the Drexel Urban Health Collaborative, and she'll pass the baton to the rest of the team as we move through the platform. So Amy, take it away.
Thanks, Jenny. Thanks so much for your introduction. And we're so excited to see everybody here. Thank you for joining. My name is Amy Auchincloss, and I am an associate professor of epidemiology at Drexel University School of Public Health, and the lead for the health inventory data, Big Cities Health Inventory data platform. So we have some polls that we'd like you to take a second to fill out, and I'll be sharing the results with you in a couple of screens. So today I'm here with my colleague Saima Niamatullah, and we are at the Urban Health Collaborative at Drexel University School of Public Health. The Urban Health Collaborative supports projects on health in cities across the nation and around the globe, and we're mostly using data to document health inequalities and inform ways to reduce those inequalities. And you can find out more about us at this URL right here. Now, we are thrilled to continue our partnership with the Big Cities Health Coalition to develop their platform. And a big thank you to the 35 BCHC member cities. These are the cities that are in our platform, and many of these cities have supported the data platform over the years. We're so happy that Nashville has recently joined the Big Cities Health Coalition. We don't have Nashville data up yet, but we'll be adding it this year. This is and the results from our poll we might see in a minute. Great. I don't know if you can see this on your end, but good. A majority are from local municipal metro government, awesome, and some nonprofit and also state government, as well as some academic folks. So before we get started with the demonstration of the platform, I wanted to just give you an overview of a few things that are in the platform. So we have over 125 metrics representing about 200,000 data points, and they're grouped into these 11 categories that are shown here on the right. This is another poll for those of you who have looked at the platform. You can tell us which features of the platform you've been using. So metrics were chosen because of their public health relevance, for example, alignment with CDC's Healthy People goals, or because of their ability to highlight demographic and socioeconomic disparities in health and healthy environments. And many of the BCHC, many of the metrics were part of the platform already. That was prior BCHC's prior launch of the platform. A major feature of the platform is the data are uniform and standardized across cities to allow for comparability. Most of the data originate from over 25 federal and state data sources. Compared to other platforms, this platform has newer data, many more metrics than other platforms. The data are city level versus many platforms are mostly state or county level. And many of our metrics have data for racial and ethnic subgroups. The platform currently includes years 2010 through 2023, and this month we finished updating the platform with available data through 2023, including the natality metrics and mortality metrics, as well as the most recent census year 2019 to 2023 from the American Community Survey. We also updated the climate metrics that we showed last year on a webinar, in case you joined then, for heat waves, longer heat wave season, and climate disasters. We're very excited to announce that we've greatly enhanced the information available for Native American and Alaska Native health subgroups. So for all cities with available data, we added natality metrics and also census metrics on social determinants of health. And for 3 BCHC cities with enough data, we added 13 mortality metrics so that's for Phoenix, Tucson, and Oklahoma City. To date, the platform has had over 100,000 visitors, and users are mostly telling us they're using the platform for surveillance and evaluation. Some cities are also populating their own data dashboards using the data from our platform as inputs. Examples here are Long Beach and the District of Columbia, and BCHC recently added this past fall the widget that takes users from their platform directly into the charts for the BCHC web data platform. Lastly, we want to draw your attention to some data summaries. So keep checking out the What's New page. Saima will show you where that is on the platform. This past year, we've created data summaries for childhood lead poisoning, drug overdose deaths that focused on different substances that were contributing to those overdose deaths, and the new climate metrics. And we have, I'll just show you the polling from what folks are using the platform for. Inequities, multiple cities, single cities, great. Or 60% haven't used the platform. Welcome, this is for you. So I'll hand the mic over to Saima.
Thank you, Amy. Good afternoon, everyone, and thank you for joining us. I'm Saima Niamatullah. I'm the data analyst for the platform, and I'm responsible for the data management for the site. Welcome to our quick tour of the Big Cities Health Inventory, a resource for exploring the health of the largest urban centers of the US. So the web site address is bigcitieshealthdata.org. It should be in the chat. Let me start sharing my screen. All right, so this is the homepage. There are multiple ways you can start exploring our data. So these are the 4 main ways you can view the data in the platform. That is, explore a big city, compare cities, inequities, and view a metric. You can also click on these boxes directly to go to the data, or use the interactive map. If you click on the city, it will go directly to the data for that city. I would like to draw your attention to the boxes in my left-hand side. If I click on select a metric, it gives the whole list of the 127 metrics we currently have in our platform. To simplify your search, you can filter by categories. So these are the 11 categories. For my demonstration today, I will use drug overdose deaths. So I'll select mental health and substance use. And under substance use, there's drug overdose deaths. If I click on the it will take me directly. So if I click on select a city, these are the 34 cities for which we have the data currently in the platform. I will select Tucson, Arizona. So this is under Explore a Big City. This is the city page for Tucson. On the upper right corner, you see there is a blurb giving some information about the city. This page populates with some pre-selected metrics. We have drug overdose death and life expectancy. The first chart is a trend in drug overdose death. On the x-axis are the years. Currently, we have data for 2010 to 2023. The hovering over the point will give you the exact value for the year. In our platform, we can view data by population risk groups by using the group by. We can view data by race, by sex, by race and sex. I'll select race. So this is the trend by race. Each line represents a group. Hovering over the label highlights the data for that group. So we have, for races, we have data for non-Hispanic white, Asian, Hispanic, Black, American Indian, or Alaskan Native, which is a new addition this year. If the chart seems too crowded, you can click on the label to dismiss the data for that group. In the top right corner, there's a hamburger, which gives users some options like viewing the chart in a full screen or download the chart in image formats. And the download data allows users to download the chart data for the chart as an Excel CSV. Another option for downloading data is the download form, which is in the footer of every page. I will show the download form at the end. Users can view, also change the years using the year. All years gives a trend, and also, you can also choose a single year of data. To dismiss a chart, you can just click the X and add more metrics using the Add Metrics button. There is no limit to the number of metrics that can be added. You can add the metric from the whole metric list, which is available at the bottom of the metric search bar, or from the drop-down menu. This bar is also searchable by keywords. For example, searching for deaths will bring up all the mortality metrics in our platform. So this was viewing data for a single city. The most popular feature of our platform is the compare cities, which allows users to compare the data for multiple cities. To compare cities, we first choose a primary city. Cities for comparison can be chosen in multiple ways. One is choosing all cities, which allows users to compare the data between all the BCHC cities, or 5 comparison cities, which is a list of 5 pre-selected cities, which are similar to the primary city based on certain demographic mortality characteristics. You can just select any city from the list, or just dismiss using the X. I will choose all cities first. For metric, I'll choose the drug overdose deaths. So this is the BCHC cities, drug overdose deaths for all the BCHC cities. On the y-axis are the cities. We also have a US total reference line, which gives the national value. By default, the cities are arranged in alphabetical order. We can sort by high to low value using the sort by. To put the cities into context, we can group cities based on certain city characteristics using the group cities by. So we can group cities by region, poverty, population, density, or segregation, and select poverty. So the cities are now grouped with the less poorer cities on the top and the poorest cities at the bottom. In this page 2, you can add multiple metrics, and there's no limit to the number of metrics that are added. We can view data grouped by the race groups, but this option is available only if less than 7 cities are selected. Hovering over the eye icon gives users some information about the limitations to the selection of those options. You can also view the data by time trends, but only if fewer than 7 cities are selected. In the next tab, I have selected few cities and metrics, drug overdose death, and uninsured, which is the % of the population without health insurance. So for if drug overdose death, I can view the trend and select all years. So this is comparing the trend for the different cities. Each line is for a city. So we also have the national value. We can also view the data group for We can also view the trend data by race using the group by, in which case the different races are broken down into the different charts. So we have the chart. We have the chart for Asian, Black, etc. So this was compare cities. In our platform, we can also view inequities in the inequities tab. To view inequities, first we select a metric. Let's select uninsured. And cities, we can select all cities or a single city. I'll select all cities first. So this is the racial and ethnic inequities in uninsured. The different panels are for the different races. On the y-axis are the cities. The central axis is at 0. In equity, each bar represents the absolute difference in rate between the minority group minus white. So inequities can have both positive and negative values. A value of positive implies the rate for the minority group is higher than the white. If I hover over the bar, we get a little explanation for the value. For example, in Houston, Texas, compared to white persons, Black persons have 10.44 percentage point higher uninsured all ages. And a value of negative implies the rates for minority group is lower compared to white. Similarly, in the next panel, we have the Hispanic white difference. And below we have the Asian and white difference and the American Indian Alaska Native white difference. In which chart? The fourth option for viewing the data in our platform is view a metric, which I'm not going to go into today. But I want to talk about ways in which you can users can share the data. Using the share button, you can share a link, you can copy a link to the page that you have created. At the top right corner, we have the hamburger, which allows users to download the chart images or the chart data. For those who want more flexibility in downloading the data, you can use the download form, which is present in the footer of each page. All the data in our platform can be downloaded free and without additional permission, except filling out this form and agreeing to the terms and conditions. So the data can be downloaded in as a Excel CSV. Either you can download the entire data set or filter by the metric. You can either select all metric or a single metric, or filter by your city, or filter for the year. Selecting all metrics, all cities, and all years allows users to download the entire data set. We highly recommend those who are downloading the data to download a codebook and a technical documentation, which is linked here, to get more information about the data structure and the metric methodologies and definitions. If you want to download the technical documentation without downloading the data, a link to the technical documentation is also available in the FAQ. This is the first question, links to the technical documentation. For those who want to contact us with any questions or suggestions, please fill out this web form we have here. And finally, I want to show the what's new page, which is here in the top navigation bar, which links to all the new updates to the platform, as well as links to the research and the reports that are conducting using the data from our platform. That's all for me. Thank you all for joining us. For those who are, I hope you have fun playing around with the portal. And for those of you who want an assignment, here is a suggestion for visualizing drug overdose deaths. The task is to use the Compare Cities tab to 1, visualize the drug overdose deaths from 2010 to 2023 for your city compared to the US rate. And second task is visualize the drug overdose death rates for 2023 for your city compared to 4 cities and group by race and ethnic groups. Let us know if you run into any difficulties. We'll be happy to troubleshoot after we finish the Q&A or by email. Now I'll hand the mic back to Amy.
Thanks, Saima. Yeah, and Saima is also going to drop this task into the chat for anyone that wants to try it. So finally, we have just one last poll. If you can, when you get a chance to give us your thoughts on that, it would be great. And any comments or questions, please put them into the webinar chat space. Elizabeth, you can, it's the Q&A feature, the Q&A feature, so that your questions don't get lost.
Great, thank you. So while folks are answering your last poll question, I'm going to start off with a couple of the questions that we got during the registration process and also that have already appeared in the Q&A box since we started the webinar. So we have a question in the Q&A box asking for some more details about the sources of these data, where you're primarily deriving them from.
Yeah, so each chart, once you visualize some of the data, you'll see that each chart has the data source in the footer of the chart. And as well, make sure to go to the technical documentation because we have a lot of information there on specific data sources. In general, most of the data are being sourced from federal and state sources. There's a few that are not those, but many of the data sources like the natality, mortality, the census data are from federal sources.
And I know from using the platform and talking with you about this before that that it's noted when the data that is being reported as county data, not city data, that it's specifically marked as such.
Right, right.
Kind of a related question that's been posed a number of times and I know came up in the registration questions is how the race and ethnicity categories were chosen and what sort of the reasoning behind that.
Good. Yeah. This does tend to come up. So the categorization of race and ethnicity were limited by the data source, and in some cases, sufficient number of cases in order to display the data. So we do acknowledge that the classification is not ideal in some cases, in many cases, but this is what is available in the raw data that underlies the data platform. So most of the classification comes from the Office of Management and Budget, which has standards for classification. So there is some detail on this in the technical documentation as well. So there is some variation across data sets in how racial and ethnic groups are classified. And so we're mostly just using whatever data classification is already available.
And kind of some related questions on sort of how things are categorized, so and what gets displayed. Can you talk a little bit about why is it those three cities when the Native American, Alaska Native, American Indian, Alaska Native data was added, why those three cities for the mortality data?
Yeah, those three cities so our platform is city level. So it's not if it was county level, maybe there'd be some different counts, but for city level counts, the Native American Alaska Native population is not high enough for all of our cities to actually be represented in the death counts for all of the cities. There are large enough populations in Phoenix, Tucson, and Oklahoma City to count those deaths. We have minimum criteria for confidentiality reasons that the federal government requires when users manipulate the data and create rates like we're doing. So we have to meet minimum number of observations for those, and also make sure that that there's a sufficient amount of data in order to be even displayed in the chart. So this is why we had not previously rolled out Native American and Alaska Native counts. But based on our webinar feedback, actually for I think the last two years, this was one of the requests, and it's a really important request. And so we worked to make sure that we could honor, at least for some of the cities, we could honor that request.
Another question about sort of definitions. How do you define the city for this data?
Yeah, so it's using the census boundary called places. And that may vary somewhat from the legislative boundary, but in many cases, they're aligned. So yeah, it's the census place boundary for those of you who are familiar with the GIS files and from the census.
Gotcha. Thanks. This question is more about kind of how to use the platform. So how do you, one of the participants is asking, how do you change the type of chart that you're looking at? Not exactly sure which.
Let me turn that over to Saima. I think they may be, that question, are they able to take themselves off mic? Or that may be about trend versus static single year. Saima, you may be able to.
Yeah, and Anita, while Simon's queuing that up, if you have some further details about what you're asking, feel free to put them in the chat and we can share those so that she can explain.
So since we have multiple views for the data, if I share my screen, if you go to explore a city, sorry, you can maybe it's a little slow. So and okay, it's work now. So this is the trend data. The trend data is when we have for years, all years are selected. If you want to get data for a single year, you can select a single year for which you want the data, in which case you have the bar chart for the single year. And also in the compare cities page, only trends can be seen only if less than 7 cities are selected. So for any metric, if the years are set to all years, we see the trend data, and changing to a single year will change the data to bar charts.
Thank you. You nailed it. So Anita says in the chart, maybe I blinked, but I saw it go from line chart to bar chart and I couldn't figure it out. And then as soon as you did that, she said, aha, that's when I blinked. So I think you answered the question. Thank you.
Just to note that because Simon was showing a little bit in the demo, there is a I button, a little information button that if you run into problems and your graph doesn't render, check the I button because there may be some conditions under which it's not able to render based on the options that you've selected in the pull downs. So for trends, we can, because there's so many cities, we can't show trends all together, all of the cities together. So to look at trend data, you do need to select 6 or fewer cities.
This question was, oh, actually, I'm going to prefer the questions that are coming in while we're actually holding the webinar. So Ryan's asking, I love the added Native American aggregation. To close the gap data disparity in missing murdered Indigenous persons, it would be a helpful request to display data on missing persons by race. Overall, this is a great step in supporting the Native American community. So more of a adulation than a question. Thanks, Ryan. They did put a lot of work into this, so appreciate that.
Good.
So a question from the registration process. So there are data gaps in the federal data sources, and in fact, more now than before. How do you address those data gaps? What's the process there?
Yeah, I mean, some of if the raw data really don't exist at all, we really can't address that. We are hopeful that the raw data that's used for much of this work will not disappear. So for example, the natality and mortality, which comprise a lot of the metrics, are compiled first by many of you at the local level and state level, and then reported to the feds, the Federal Vital Statistics, which is where we actually are requesting. We have a involved process of filling out data requests and legal agreements to obtain those data. But yeah, data gaps in the future may increase. We're holding our breath and hoping that they won't. Why the youth risk behavior study or surveillance system is one data set that over the past 10 years has been more and more. There's been discontinued participation at the state and local level, and Elizabeth recently shared that some of those teams may not have been funded moving forward. So there is concern that there may be some data sets that we can't get a hold of, and we'll have to just figure out what we can do. There is some for some data points, there's some stability over time, at least within particular windows that we can extend the data out. But yeah, we're gonna cross our fingers and hope, as I'm sure all of you are hoping as well, that there's still robust support for surveillance data like these data that we have on our platform.
And certainly a lot of BCHC and a lot of other organizations are doing a lot of advocacy to make sure that those data sets continue to be continue to thrive and be funded. We're doing the best we can advocacy wise. So another question about kind of trends over time. This one about something that, we're kind of seeing a lot more reporting on in the press, for example, is that overdose deaths have dropped nationally, and in many of our cities are also dropping. And in fact, for 2024 and early 2025, the numbers are even better, which are numbers that are not yet on the platforms. They're not federal yet. Anyway, point being that the numbers are dropping. And so the question that this person asked is, kind of given what you've seen in this data, what do you think are some good theories about why this is happening?
Yeah, I mean, I guess first to just step back, at the federal level across the US, there has been some slight declines. We should be careful though that overdoses still remains a leading cause of death for those in the what CDC is reporting in the 18 to 44 age group. Based on the BCHC platform, cities like Baltimore that had extreme high rates in the last number of years have shown a decline. But other cities like Philadelphia on our platform are showing more of a leveling off rather than a decline. Leveling off is still good though, thank goodness. So other cities like Kansas City and Charlotte, the overdose rate is still increasing. I just put into chat an example of some trends over time. So this is when users pick just a handful of cities, less than six or less cities, you can look at trends over time in deaths. And so that's a display of that. I mean, I think public health advocates and cities are hoping that some of the investments that they've done, both in the lab reporting and trying to identify drug deaths and sources of particular drugs, as well as the overdose death prevention efforts are paying off. So we're crossing our fingers that that's the case. It is still a major public health problem, though, that we need all hands on deck to recognize and to continue to fund, put significant funding and effort into the overdose death issues.
Mm-hmm. Yeah, and to your point, I know that the dropping rates don't always hit every demographic at the same time, too. So the differences aren't just across cities, but also race and ethnicity groups and even age groups as well.
Yeah, within cities, good.
Right, right. Let me see. What would be a good question to ask you?
Does anyone have any, while they're playing around, to let us know, put something in the chat if you want some more demo pieces, or we're also, after the webinar, we're happy to stick around if there's any questions on that.
And while we're doing that, we also got a question during the registration process about how to use, there's a lot of really good data in this platform about that highlights health disparities and health inequities. And so the question that this person asked in the registration was about how to use that data and the long-term health impacts with audiences that are more reluctant, really don't want to talk about health equity or even are adamantly opposed to it. In other words, how do you use health disparity data effectively in a world that is not always on board with DEI? And which is a great question and a complicated one that we certainly can't completely answer in this. I'm going to take this one because I'm I'm the messaging person, and BCHC has done a lot of messaging research in the last couple of years, specifically around some of these questions about, how do we talk about public health and public health information in the current climate. So one thing I would encourage you to do is look at some of the messaging research on our site. As soon as I finish answering the question, I can put up some links to that. But kind of the upshot of it is this, that one of the things that we have found in our polling research to be very effective is when you are speaking to audiences that are not kind of already on board with, wanting to address health inequities, say, is number one, to find a shared value that you do actually share. So we all want to live in safe communities is a good example of this. Kind of start off with something that we can all agree is a future that we want to see. And be sure to focus on the work that your health department is already doing, that you can already show is effective to get to that place. And we can talk about, one of the things our research showed is that when we talk about racism and its impact on health in a way that focuses on solutions, focuses on the fact that this is a human-made problem that we know how to solve, even if it's going to have to happen over the long term, that kind of framing is much more effective. That, oftentimes people's reluctance to talk about racism and its impact on health is more about feeling futility rather than, a kind of specific opposition to talking about health equity. So you're not going to win everybody over, but there are some tactics in this messaging research that I think can be helpful. And like I say, I'll in just a second, I'll post some links to that research so that you can take a closer look. And I think, there's a question about if one of my epidemiologists has a specific question about data or definitions, who is the best person for them to contact? And it looks like Saima has answered that. Saima, if you wouldn't mind putting that into the just general, or like letting I think it just went to the original asker and the panelists. If you could post that.
Sure.
Response.
Yes, if anyone is free to email either Amy or myself, I'll put our email addresses in the chat.
Cool. Thank you.
Okay. I just did that. And also the survey. So the tiny URL, the shortened survey link, that all of that gets immediately forwarded to our email. So that's also a convenient. There's just 2 questions in the survey. So feel free when that little pop-up happens, just jump on and answer the 2 questions. We will be very happy with you. Our response rate is low, as most people's are when they put these things on their website.
Well, I think that is the last of our questions. So yeah, definitely want to thank you all for being here today. Jenny, thanks for getting us started, and Amy and Saima for showing everyone the platform and explaining how it works, and Walker for making sure that we're our sound and that everything's running properly, because we know I'm not good at that. All right. Yes, we will. And just to answer another person's question, we will be sending out the slides and a link to the recording after this webinar. Thank you all for being here. Take care.